Good morning. Good morning, everyone. Good morning, Kay.
Good morning, Dr. Nurse Paul. Good morning, everyone, viewers. Good morning, good evening, and good afternoon. Are you guys still sleeping? Because we're 1 hour uh, early
we,
here in the United States because
I
of
know.
daylight saving time. We move
Yeah,
forward one
spring.
hour.
Yep, spring forward. Yep. And everyone, I'm very happy for this episode, Kay. We've been wanting to do this show for a long time. And it's very timely to talk about pay structure for nurses. How can we improve pay for nurses, and also, satisfaction with doing the job? I know nursing in itself is very fulfilling inherently, but we know that there are nurses that are experiencing burnout, and we are having nurses leaving the bedside, and we don't want that because the healthcare will crumble without nurses.
Absolutely. It's very important to take care of the people taking care of the patients. It's very,
R-
for me, I'm a businesswoman, and I always say the success of your business always comes from the people who's taking care of your business, and those
that's
are the
correct.
people who put in the facade of your business, called the frontliners. Who are the frontliners? Who's the facade of your business? If you take care of them, your business will be very successful. So
That's correct. And today, Kay, we're going to talk about this is our episode 22 for DNP Unlocked. Can you believe it? 22
wow,
episodes in.
I know
And
it's been 22 times we've been waking up early on a Sunday, right?
right, right. And I think a lot of nurses still don't know what we do in DNP Unlocked. We talked about stuff that can help our immigrant nurses, but not only that, a lot of topics that we talk about can also help local nurses here in the US, because we've touched so many things in this show: finances, jobs, opportunities, and today we'll talk about pay structure. And we would like to invite viewers to join us in the comments section. I see one already. Ali is joining us from LinkedIn, and he said he is so excited to join us in today's show. And Kay, we have a special guest.
Yes. So, hi, Ali. I'd like to say hi first. We've been friends in LinkedIn virtually. I haven't met him, but I would love to meet him. I saw him when we both were in Nurse Hack in, I think that
Nice.
was last year, Ali. I was there with you guys. Uh, and I'm very happy, and congratulations for that, for the winning the Nurse Hack last year for about foreign nurses. That was an awesome job. Thank you for joining us today. And our guest today, wait, she's awake.
Yes, yes, she's here.
Right, so I'd like to introduce our very special guest today. She's one of the person that I really look up to, and in LinkedIn, she's a influencer. She's the first nurse to be featured in TED.com, which is a very famous space for speakers, for very world-renowned speakers. She's the first director for nurse innovation and entrepreneurship in the United States. Could you believe that? Because before, when I arrived here in the United States, there's no such thing as nurse innovation. Everybody's like, zip your mouth, don't open unless you're asked, right? And especially when you're a traveling nurse, we are not really supposed to be like saying this is how we do in other places. But again, when I saw this nurse innovation thing, I thought, wow, this is some good space that actually nurses are the one of the best people who would invent things, best inventors in the bedside. So she started SONSIEL, which is the Society of Nurse Scientists, Innovators, Entrepreneurs, and Leaders. It's a nonprofit organization that's aiming to help and empower nurses in this kind of field. And because of that vision, they became the affiliate of United Nations. So
Wow.
SOMCIEL is an affiliate member of United Nations in terms of nursing innovation. Um, she has a lot of things under her belt, and I'm pretty sure everybody knows her in LinkedIn, especially in nursing. Everybody look into her, especially in staffing and recruitment, nurse retention. But as for me, how do I see her? She's a very good nurse mentor. She's a mother of three. Unbelievable how you do it. I don't know. She's a businesswoman, buy and selling, have created a business, have sold a successful business. And she's the consultant to many. If you have been to a lot of nurse conference, she has also been a speaker, a keynote speaker to a lot of them. Um, Again, for me, she is a very good friend and somebody who I look up to, because she's just very advocate, to our nurses. And not only that, she her passion is just like burning. If I say my passion to help you guys is burning, her passion to help you guys is like burning like that. um, let's welcome Rebecca Love.
Hello, everybody. Hi, Kay. Hi, Dr. Nurse Paul. Thank you guys for having me join you today. What an amazing
Good morning,
introduction,
Rebecca.
and congratulations on your 22nd episode. That is
Yes, ma'am. We are so happy to have you. I've been wanting to like bring you to the show. I was like, hey, please ask Rebecca if she can come to the show because I know you have so much to share, so much to talk about. And I'm a follower in LinkedIn, big fan. Thank you for gracing our show today.
You guys, it takes all of us. I think that that's the goal of the future of nursing, right? Is to get as many
Yes,
voices
ma'am.
of nurses amplified so we start actually translating the power of the profession to those who may not understand it and save the future and redefine it on our terms, right? So it's great to be here with all of you.
Thank you, Rebecca. And we have followers watching us today. Aisha is watching us from I'm sorry, I was flashing another question, but she was asking about a staffing agency. We'll talk about that in a different show. Mel is watching us from Maryland. And guys, use the comment section. We are going to open the floor later for questions. And share these to your friends, tag your friends, kindly share the show so we can reach out to other nurses who might not know that we have already gone live. But how are you doing, Rebecca?
Good, you guys. I think that, it's at an interesting time and place for the profession of nursing. A lot going on both in the United
Mhm.
States as well as globally. And I think the truth is what you're finding is an environment in which the global conversation around nursing has reached levels and places that we've never had it happen before. Because I don't think this is a problem unique to the United States, but it's a unique
That's
problem
right.
to the world. But also because of the shortage in the United States, and the United States drive economic impact around the globe. Nursing in and of itself, because of the shortages in the United States, now are causing new pathways to open up. And I mean, Dr. Nurse Paul, you know that better than others. And Kay, you guys all came here into the United States with a very clear focus of what the future was going to be for yourselves and use nursing to, be that vehicle to get there. But yes, that's what's going on, right? Lots of exciting stuff.
Yes, ma'am.
Yeah, absolutely. So, Rebecca, you are very advocate. I was saying, if I have advocacy in helping our foreign nurses, you have the advocacy to help like global in a global scale, by affiliating yourself as well with the United Nations. That is very remarkable and very interesting thing that you guys have done. How do you see how would you see this new reimbursement? Can you talk about this reimbursement model that you guys started? Because for me, when I was traveling nurse, I was thinking like, oh, traveling nurse makes sense to a lot of people because it really brings flexibility. It brings a win-win relationship between employers and nurses. But because travel nursing is very expensive, it's not sustainable. Right.
Hmm.
So for me, I said it can be done temporarily and it's very, very minimal. You can use it,
Hmm.
but not, this is not really the solution for it.
Yeah.
So when I heard about the nursing reimbursement idea, I'm like, that makes total sense because people will invest on things that will generate certain amount of return of investment. If you're not returning investment, there is no reason to invest. So why would people invest in nursing when you're not really seeing the value of nurses?
Yeah, no,
Or
okay. I think it's a good question. And talk about Nurse Paul. I think what we have to talk about is the history. And I think that most nurses don't know that nurses are cost to healthcare system. We've heard that
Hmm.
term thrown around, but what does that actually mean? As a cost, it means nurses have no billable services that they can bill insurance for the delivery of work in which they do. Now, this is different than every other healthcare professional. Occupational therapists, respiratory therapists, physical therapists, surgeons, all provide work that when they provide this work, they can submit a claim to the insurance company so that work is paid for by the insurance company. What happened in nursing ties back in the United States to over 100 years ago. And if you guys don't mind, I have to tell you a little bit about the history so you understand why the situation is what it is. So you guys may not be aware, but in the United States, over 100 years ago, women did not have the right to vote. And this was a challenge because about 60 years into the fight, there was a day of an election, the day before Woodrow Wilson's election. The women's suffrage movement, which was the right for women's right to vote in 1913, organized the largest march for women's right to vote in the history of the United States. Now, at that time, American nurses had not gotten involved in the women's right to vote, which was crazy because almost 100% of all nurses at that time were female. Now, at that date of that march, nurses joined that march in 1913, organizing and effectively changing the landscape so that in 7 years' time, in 1920, women in the United States got the right to vote. And in the 1920s, nursing became the largest economic vehicle for women's financial independence in the history of the world. At that time, nurses, just like physicians, billed for their services to private families who hired them to care for their infirmed. At this time, hospitals were places of deplorable conditions. Only the most destitute would seek care there. But as surgery started to get better, private families started to hire private duty nurses to go into the hospital. Care started to get better. Hospitals started to say, oh my gosh, we need to hire these nurses in here to start driving better care. That's what they started to do. And in every bill in the 1920s, there was a billing line that said nursing services in which patients would be charged for the nursing services in which they delivered. Suddenly, these women started to have the idea of the amount of economic impact they were having to hospitals. But at that time, hospitals were run by men. Physicians were men. And as the historian Donna Deere showed, they were looking for a model that would capture nursing services, but keep nurses as far away from the money as possible. So as national insurance came to place in 1930s, they looked to a model, turned to hotels, saw maids had been rolled into the room rates of hotels, and they rolled nursing into the room rates of hospitals, forever placing nursing as a hidden cost to the hospitals and making it that more nurses consistently equal more costs. And if you guys know anything about business, we don't invest in cost, we cut costs. And that's what we've done in the last 100 years in nursing. So what we're doing today is with the, about a year ago, almost to this date, we launched the Commission for Nurse Reimbursement, which is fighting to design a new reimbursement model so that nurses are no longer cost. We can bill for our services, and therefore we will not continue to staff nursing in the United States to the lowest cost denominator and be treated equally like every other profession in healthcare who can bill for their services independently.
Wow, that is powerful, Rebecca, because if you put it this way, nursing still today is still a female-dominated profession, and it's been 100 years, and we're still paying the nurses in a very archaic way. So to put it in a perspective in my own practice, so I'm working as an NP now. I'm in my first year of practice. I know for sure that for every time that I see a patient, I can bill for my services. In fact, I can run my numbers and I know how much revenue I bring to the office. With that, I can negotiate my contract. I can negotiate my benefits. I have more protection in the sense that they don't necessarily want to fire me, because firing me can make them lose $1 million in revenue automatically. But we don't see this with nurses. We see nurses as as something of just a number for the hospital, where turnover, we don't care about turnover. We don't care if it's like a revolving door in the hospital, because they can just hire new nurses and cut down that cost. They don't have an incentive to keep nurses in the bedside. They don't want to keep nurses getting all these benefits and incentives. They are actually doing some pay suppression, if you put it this way. Iowa just passed a bill to suppress travel nursing and all that. I mean, it will still operate with the law of economy, supply and demand, but it just doesn't make sense to me why we will try to suppress a profession that is highly in demand based on BLS data. Why are we going to suppress that pay, right? But you're right. It's because we are considered a cost. But if we can bill for our services, does that mean we can also negotiate our contract? because now we are billing for everything that we are doing for the patient.
Well, so I'm not sure we're going to bill for everything we do for the patient, just to make that clear, Dr. Nurse Paul, because I think that to your point, this is not about driving up costs, but to your point, as a nurse practitioner, you can bill, but we cannot. And to your point of in these situations of what we're seeing is what's referred to as rate caps, which we're seeing not only in Iowa, as you're saying, and we're seeing it also that's already been passed in Massachusetts, in Minnesota, other states have done this. And what that does is it eliminates free market economics, which is actually a violation of anything in capitalism, which the United States is proud to say they're a capitalistic society. The difference is in the United States,
and they cap the pay.
Exactly. But in the United States, when it comes to nursing, actually, we are one of the only professions that enters into a capitated payment model. That means that over the course of a 20-year career at the bedside, it means that on average, nurses only receive a 1.6% increase in salary per year, which is less than half the cost of living data. We actually saw the only meaningful increase in nursing salaries in the year 2020, when the average nurse saw an increase of pay of 3.26%, even though the average American saw the increase of their wages go up by over 5%. Nursing has always been kept down from a payment model because we enter into this place where they're saying, look, this is as much as insurance is willing to reimburse on the room rate. Therefore, we can never increase nursing salaries to keep pace with inflation. And when we actually hit the 20th year of our profession, we cap out, and that is the most money you will ever make again as a nurse. This happens nowhere else in society. Now, the craziest thing is we're willing to rate cap our nurses, but we're not capping the pay of the CEOs or the administrators in hospitals or their expenditures. To me, this makes no sense. And to me, this is why nurses should be marching in Washington, D.C., because we are the only profession that we are capping rates for. We're not capping rates for lawyers, and we're not capping rates for teachers. We're not capping rates for police officers, but we're capping rates for nurses, making the free market enterprise not work, and why we see the amount of turnover. And to your point also, Dr. Nurse Paul, the truth is that it's much more affordable for systems of scale to have much less experienced nurses because they cost significantly less. And there's a lot of question around wage suppression, especially of the nurses as they enter the profession, being that they have been held stagnant for the last few years. There's a major debate going on that across on social media, with the most recent report coming out from Olga Yakushova based on BLS data, that it looks like wages are actually increasing. But based on self-reported data by organizations such as Nurse Wallet and Medley, it actually shows that if you look at actual core wages, they've remained nearly flat, where BLS data incorporates a large scope of data, including overtime and everything else that goes with this, to actually misconstrue the facts around nursing salaries. So why do we need to change this model, as you asked? The reality is, if we do not change the model, nurses will always continue to be staffed to the lowest cost denominator. Our profession, as you mentioned, will churn and burn. And the reality is that I believe until we change this, the truth is that we will not solve this. And the reality is more nurses will leave. And what this does mean is what we saw in the 1980s, where nurses started to demand increased wages. What they did is they did open up the entire immigration pathway for nurses to come into the United States. Those wages were historically at the lowest levels of nursing pay that the United States has ever reportedly paid. And this is a way that I do strongly believe that nursing is the path to the American dream. I am all for international immigration into the United States. But with that, I think, as Kay and I have mentioned, the question becomes, at what level is fair? And making sure that nursing has a livable wage in which those who come and work in the conditions that they are paid correctly for the work in which they perform.
Right. So it creates the ramifications. We're starting to realize the ramifications of the current pay structure to the economy, to the healthcare industry. Because if you don't pay nurses well, they also leave. And nurses right now in this generation is more empowered, I guess.
Yes.
And if you look at it in the immigrant nursing community perspective, what happens is, because there's a continuous revolving door of turnover rates of nurses here in the States, and hospitals don't have an incentive to really keep nurses that have been there for a long time because there are additional costs. They can just hire immigrant nurses at the lowest cost possible, right? But also opening up a chance for nurses to be placed in deplorable conditions, deplorable contracts. So that kind of like opens up a Pandora's box. What do you think, Kay?
So actually, it does. Yeah, that the thing is, the I've been traveling for 17 years, probably one of the longest traveler in the United States. And as when I go through it, it's there's no really for me, there's no shortage in big cities at all. If there's
That's
shortage
true.
of nursing, there's actually shortage of nursing in the rural area. But now we're implementing federal rules of immigration that will be send nurses to cities as well. That will displace those experienced nurses in the big cities. What we really have to focus is send those nurses to places where there's really a need. For me, that's my thing. There's no such, for me, I'm not anti-immigration, I'm an immigrant nurse, and this brings an economic advantage to a lot of nurses worldwide. And at the same time, nurses, international nurses who come to the United States also tend to give back, and that helps everybody up. But the problem is, if you are going to put a nurse in a financial situation receiving the lowest pay, which is two ways behind because of the prevailing wage that are set like that, plus the inflation that has not reflected in the past 2 years. We have an inflation of almost 9%, and the salary is what 1% raise. It's not going to catch up, and that will, I think, in the next 5 to 10 years, if this is not going to happen, or like improvement of nursing salary or conditions of workplace, then I think nurses will fall under minimum. I have heard a lot of nurses now being approved under Medicaid because they're under livable wage. And I have heard of foreign nurses being instructed by their employer to apply for CHIP for their kids, apply for Medicaid upon arrival, which is absolutely ridiculous because your employer, you promised them health insurance, and now their salary cannot even afford the health insurance that you're offering. For a family of four, I have heard somebody needing to pay almost $1,000 for every month.
Wow.
That's only employee part, not the employer part. The employee part was almost $1,000 for a family for. How can you live with that with a salary of $30 an hour? How can you afford it? No. So if this nursing reimbursement is not going to happen, the one that I'm thinking is a lot of people are pushing for racial law, which is a lot of hospitals are not agreeing either. There's like a battle of, leadership. I have seen that in LinkedIn. I've been
Capitalist
following
versus,
LinkedIn, and I
yeah.
said, okay, our nursing leadership is torn between racial and no racial. So I'm like, I don't think this is going to move forward anyway. But if you really pay attention, operating room nurse, I'm an OR nurse. We are one-to-one patient. We know our value. We know our value. And why is OR nurses one of the top paying cath lab procedural? Why? Because they see the value that these nurses bring in. If you're very short of an OR nurse, what will happen? Number one, divert the patients for emergency. OR is closed. Then there's no money generating for the hospital. If if nursing is understaffed in the OR, we're gonna have to shut down room. What does it mean? No one can operate. Nobody can operate in the patient. No surgery. Nobody's gonna come. So what we'll do? Hire a travel nurse. Pay them extra if you want, because these people will bring in money to the hospital. One nurse that is off operating room, one OR is shut down, and that will cost them almost 100,000 probably in one day. So this is the thing is, if we don't, push in ratio, there is something that we should be putting in place that will put value in the work we do. Because if, again, nobody will put value in nursing, nobody, I mean, if we're not putting value to it, I don't think anybody would put value to it. So
Right.
I think every nurse should understand that you have a value, you bring in income to the institution that you're working, and it's not just about coming here. You know, I think every international nurse should come here thinking that we have to work all together to have a sustainable profession.
Yeah.
So, but by the way, segue. If you guys are listening, if you guys are in any part of the world, and you're planning to come here, listening to Rebecca is like your IELTS review. Okay, she's from Boston.
Nice.
Thank you, Rebecca. Just a joke there. everybody study for IELTS. Listen to Rebecca's podcast. If you master her, listening to her, you're gonna pass your IELTS. No, guaranteed.
I'm
Okay.
speaking a little fast. Thank you, Kay. Tell me that. Yeah, I can slow it down too.
No, we like it. We like it like that. You train them hard. When they get to the exam, it's going to be easy, right? But anyway,
Well,
um,
Kay, you make a very interesting point on ratios. There are only 2 states in the United States that have nurse to patient ratios.
Mhm.
And what that means, it is a state level mandate, which actually determines how many patients a nurse can have. Now, the first state that passed this was California, and that was nearly 20 years ago. But we just had Oregon also pass this. And you're
Mm.
actually seeing the first time ever the federal government is actually looking to enforce nurse to patient ratios in nursing homes, right? And I think that
Mhm.
this is actually a critical directive and one that we should be doing. What we've also seen happen in the long-term care space is over the course of the last 20 years, what you've seen taken in long-term care was a non-for-profit world that has slipped to for-profit. So 80% of all nursing homes in this country are now owned and operated as a for-profit entity, which means they continuously staff nurses to levels in these places that are to the lowest cost that the
Right.
institution can do, which we know as facts based on National Institute of Health Studies, that the one direct correlation that leads to increased rates of death within any setting is the amount of patients a nurse has. Now, the reason that every system opposes nurse to patient ratios in this country is exactly this. Nurses are cost. They don't want to increase their costs to mandate at that point in time that the minimum amount of patients a nurse can have, because they recognize that there are going to be financial pressures to staff in certain times of the year
Mhm.
to actually increase those ratios because their financial operating budgets can't support maintaining nurses on a med surge floor of
Mhm.
1 to 5. So they're going to increase that to 1 to 6 and 1 to 7 and 1 to 8 on night
Mhm.
shifts so that those costs are remaining flat. This is the problem. It is this model. It has nothing to do with the outcomes for patients. If we think
Mhm.
that hospitals are pushing back because they want flexibility around nurse to patient ratios to make sure that we're dealing with the right level of acuity per patient, the reality is that is not the reality. The reality is they don't want ratios ensured because the reality is it is a financial situation that they do not want to have to maintain that kind of level of responsibility to the nurse
Correct.
and the patient. So I think it's very important to talk about those things. I think that you will actually
Mm.
see there's 19 states looking at nurse to patient ratio
Right.
legislation. And I think until we either one get a reimbursement model that actually so that nurses the hospital makes the same amount of money if they staff a nurse 1 to 5 as if they've staffed them 1 to 8. So
That is
therefore they're going
correct.
to always try to go to that direction. So I
Right.
actually do think we will see, if we do not get a reimbursement model for the United States, I believe for nursing, you will start to see actually more and more states fall, because we don't have a shortage of nurses in the United States. This may shock everybody. We have a shortage of nurses willing to work in healthcare environments as they are today.
Mhm.
In the United States, we have over 5 million nurses.
Million.
Comparing that to the UK, who has 450,000, we have 10 times the amount of nurses in the United States than anyone else, but we have a shortage of those nurses willing to work in healthcare, and they have left the bedside. In fact, before the pandemic, 57% of new grads left the bedside within 2 years of the practice. During the pandemic, that level went up to 70%. And actually, shockingly, not that it is too surprising, almost 70% of all bachelor's prepared nurses leave the bedside and bedside nursing within 2 years of practice. We are failing in retention,
Right.
as you said, Dr. Nurse Paul,
Mm.
which is
Right.
there's no incentive to keep nurses at the bedside. So we
Mhm. Mhm.
produce ignore and churning and burning them. And this is where we are ending up in serious problems, because we have a brain drain. Lack of experience is gone. The average length of experience on a 12-hour shift has dropped before from 6 years of experience prior to the pandemic to now being 2.7 years of experience on a 12-hour shift for the average,
Right.
the lowest ever recorded. And we're wondering why. Incidents of harm, death, and serious secondary events are occurring in every single hospital in the United States at levels never before reported. It is not a good time to be a
Right.
patient in this country.
So I used to work ER, and ER for me, working in the ER environment in the US gave me an overview. Maybe it's just generalizing of what the healthcare looks like, because I call ER as a place where if nobody wants to take care of you, or nobody could care for you, or nobody's available to take care of you, we are those people who will be there for you. Like we see all cases, but I also have seen how fast the turnover is, and the brain drain is actually real in the ER. I'm an ER nurse, but I can honestly say this, that I would not want to be in the ER, right? Not because, I'm scared with the ER, probably, but because I've seen how young the nurses are, and I'm not saying young nurses are not good, but there are so many things that you just learn by practice and experience, and that's staying in the bedside, especially with high acuity, high volume space like ER. So for me, that sends a bad signal to me. If I get to a stage where I would need more emergency care, probably when I'm 80, what would happen to me? What type of nurses am I seeing? Are nurses still there to take care of me? Are nurses still motivated to stay because there's so much wage suppression, preventing us from lobbying for ratios? These are two of the four things I advocate globally: fair pay and fair ratios, that I think are grounded into probably the archaic view of nurses, that, this is a female dominated profession. Maybe we can suppress their wage. Maybe we don't let them step up and lobby for themselves. But I think immigrant nurses should be part of this. Immigrant nurses should come together, work with American nurses. Let's all bring together our expertise in healthcare, our voices. It is time to get past this lid. We just can't get past it. Like, we're not just a cost. We bring revenues to the hospital, but it's just hidden because we're not billing for nursing service. But possibly if we start doing that, because now I'm understanding it as an NP, that I'm billing for my services, and there is an incentive for my company to keep me, because they cannot afford to lose me at this point. They're going to lose that revenue, and it will take them time to hire another person to get up to the speed that I could produce for them. Imagine if nurses has this ability, and like you said, it's not necessarily increasing the healthcare cost. It's just putting it up front, that we can bill for nursing services, so hospitals won't try to cut us out of the negotiation table. Yep.
Yeah, let me give you an example of what you're saying. Exactly this, Dr. NursePaul. So there is actually a situation where most individuals, most federal, state legislatures have no idea that nurses aren't reimbursable. Right? They had no idea that nurses are cost. And let me give you a prime example of when this occurred. In the right around the time of the pandemic, in North Carolina, Novant's healthcare system in one of their rural areas cut 300 nursing positions. Suddenly, emergency room wait times went up 19, 21 hours. Patients were dying in the emergency room.
Wow.
So the treasurer's office was like, what is going on? We've given this healthcare system billions of dollars. How are they saying they do not have access for money to do these things? So he threatened to pull Novant's Medicaid license because they had given all this money through Medicaid. Suddenly, within weeks, they had hired back hundreds of nurses. Why? And so the treasurer office started to do a study. And he said, what has happened to the billions of dollars in healthcare that we have given to nonprofit healthcare systems in this country and in this state specifically? What they found is that the amount of billions that they had given had gone to doubling CEO salaries at these nonprofit healthcare systems, doubling CEO patients in the course of 5 years. Whereas nursing salaries in that state had only gone up at the average of like 1.15% over the course of the last decade. And physician salaries had only actually gone up 2% per year. But CEO and administrative salaries had gone up nearly 100%. So as they showed, they said, what is happening is there's plenty of money in healthcare. But because we do not actually, nurses are a cost, it's going to build new buildings. It's going to executive compensation packages, but it is not going to nursing salaries. So we know that there's plenty of money. It's just not going to support nurses. And why this is important is, as you guys started this talk off, is you cannot have hospitals or nursing homes operate without nurses. We saw this specifically during the pandemic when everything shut down and everybody else left. It was only nurses on the front line of delivering that care. We have forgotten that it was always nurses. So the reality is as long as nurses remain hidden into this structure, those dollars that are going into the room rate, which they say about 40% of every dollar that goes into a room rate goes to support the nursing operations budget. All of that, though, is if they want to do something different, they just take that and pull more money out of those dollars. So suddenly it's not 40 cents of every dollar. Suddenly it's 32 cents of every dollar supporting nursing. And this is where the inherent challenge is. We know that in Belgium, they have rolled out this model in the last couple of years where they actually reimburse for the nurse into these healthcare systems. Not only has it driven down overall healthcare costs for the country, we have seen dramatically better outcomes for patients. This is about public health. And the reality is, though, that if we continue to allow the for-profitization, though, of our healthcare system, which we're seeing with even private equity stepping in to look into buying nonprofit healthcare systems, and based on the report out of Harvard that shows those nonprofit healthcare systems which have received and are funded by private equity are showing significantly worse outcomes for patients, because when you make healthcare about profits, patients will always lose. And this is the fight of our profession. The history of what happened to nursing was largely done to destroy the economic model for women's independence. And what we have seen happen now is because nursing has still been hidden within these costs, within this historic, antiquated reimbursement model. What we're actually seeing, it is now being further used against us to the point that many people are making billions of dollars off the back of a profession because we have turned it into being about profit. And we must change the model. We must reimburse for nursing. We must stop. And when we reimburse for nursing, then we can have a fair debate around private equity coming into healthcare, because they will not be able to use hidden dollars for the advantage of profits over patients. And this is not just about our profession. Why we're fighting for a reimbursement model for nursing is not only about a sustainability for our profession, but it's a sustainability for access to healthcare for all Americans. This is a public health emergency and crisis, that if we create this model, we can change the future and stop what is happening for patients.
All right, thank you so much, Rebecca. That's very, very important to understand this, especially a lot of our watchers are immigrant nurses in the United States and outside the United States. So it's very important that you mentioned about long-term care, those situations, because majority of our immigrant nurses are actually landing those jobs. And a lot of people have come to me, Kay, why are you exaggerating, the situation in nursing home? I said, I have worked in a nursing home. I have worked in a rehab facility. That was my first job here in the United States. In my first day, I was given half-day orientation in a new country, in a new healthcare system. Half day. And what happened during the other half day? Oh, there was a patient who was having a cardiac arrest. I was doing CPR by myself as a nurse. Do you think that person will live if I'm the only one who's available to give CPR? Eventually, some people come, to help me out in that. The second day, they said, "Kay, you're the only nurse with license RN right now. So you're the charge nurse." I'm like, "Holy cow, charge nurse! I'm 22. I'm only here in the United States in for 4 months that time. This is my first time I'm getting my NCLEX license. This is the first month. How many patients I'm taking care of and I'm the charge?" And say, "Okay, 40 patients. 40 patients. Listen, I have no med surg background. I do have my 4-year program in the Philippines that we do this. But the difference of healthcare in the United States and comparable to the Philippines, what I have seen is we're being marketed. Immigrant nurses are being marketed as they are fine. They can manage 60 patients in other country. It's fine. They're used to those heavy volume. But what people don't understand when they come here is what you said. Nurses have high lawsuit. In other country, we don't have that. Patients don't sue because they don't have money. And when you really have to sue somebody, an example in the Philippines, means you really have a lot of money to sue. And you're suing a person who earns $100 an hour. I
And
mean,
I think
sorry, not $100,
important.
$100 a month, right?
Yeah, it's an important differentiation to your point. And for
Yes,
international
yes.
nurses, they're hearing 40 and they're thinking, this is great. We can do this. The difference is in the United
Yeah,
States,
yeah.
our long-term care environments are people that are infirmed to the direction that they cannot live independently, right? If you can walk and talk, you're largely no longer in a community of like a sniff at this point in time, right? These patients are very heavy patients, high acuity levels, and infirmed in a place that does not do these things. And to your point, are highly regulated environments because they are doing those things. And there is a high litigious one. So if you are not able to care for these patients and you make a mistake, because the environment is failing you, because you do not have enough caregivers. We actually found just in the state of Ohio in 2021, I believe, over 100 nurses were criminally prosecuted, healthcare workers in
Mhm.
long-term care, for mistakes that occurred because not mistakes that they just didn't have enough time to do these things. They were not intentional. And what that means is, I
Yes.
think we've always known in the United States that you could lose your license, you could lose your job, and you could lose your livelihood for a mistake that you made, right? But in the course of the last 2 years, ever since the Rodonda Vaught trial, in which she self-reported a medical error that resulted in death of a patient, we now see nurses being criminally prosecuted for mistakes that they did not intend to harm patients. And when you are criminally prosecuted in this country, you go to jail for very long periods of time. And it is a devastating trend. And I think part of the reason why so many nurses are leaving the bedside in the United States, because as much as we love our patients and our profession, we love the idea of caring for our families more. And no matter how much you love your job, you're not going to give up the rights to your family in that situation. So I think to your point, the stakes are much higher and there has not been put in any kind of protection for nurses. And that is something that is concerning. So question back to you both. When you are looking at the state of nursing from your perspective, you obviously started this conversation in to hope to bring directions to nurses. Things are about to change in the United States. There's even a movement to get nurses identified as a STEM profession, which mean dramatic changes into what will happen with regards to international recruitment, but also supportive nursing in this country. But what are your thoughts that you hope that nurses who are listening today take away from the conversation we're having and what can they do next to be successful in their careers as nurses in the United States?
You want to go ahead, Kay?
For me, I think it really is for a nurse to be successful here in the United States, international nurse, you have to understand that healthcare system in the United States is a capitalist one. I think that's the first and foremost that you have to remember. You're working for a company that is a capitalist in nature, you know, and that's where I would say you have to accept that fact. A lot of people, we've been trained, patient first. And when you come to work, there now you will see leadership profit first, and now you feel like you're burning out because both of you have different values. But for me, I think for you to be successful, of what I did was I really put myself in a situation where let me put myself in their shoes and see how the leadership is looking at this. And then I realized that okay, my managers are actually in a situation too where they have to balance both, but because they have to also, like you, have to put a food on the table of their family, they have to keep doing what their bosses are being told. For me to be the reason why I think I became a successful in what I'm doing with my profession, because I put myself in the shoes of the manager and I try to work things out for them. So a lot of those nurses are being told to work extra hours, so way beyond. And what I did was I come to the hospital the first thing in the morning. I will put my name. Yes, I'm available to extend if you need me. I'm available on Wednesday and Thursday if you need me to extend. You know, that time, you don't need to force me to do overtime against my will. I'm putting extra time. I know you guys have shortage of nurses, but you don't have to put me in a situation because I have to pick up my child at 5 p.m. The daycare is closing. You cannot put me on mandated overtime. But the way I will work with you, the managers, is I will give you certain time that you can put me overtime and I will have no problem. But these days you cannot put me because I need to pick up my kids or else I'm picking up in the police department, which happened to me already one time. And I said, I cannot. But then, so I think really putting myself in a situation of understanding that nursing, hospitals a business right now, still a business. And, we need to generate income for us also to be having jobs. The hospital needs to make money. We have to keep that in mind, but also we have to be patient advocate at the same time. So you have to understand both business and nursing. My next question for you, Rebecca, to follow up with that, with the nursing reimbursement, if it ever goes forward, will there be a follow up with or change with the education, with the academics? Because nursing reimbursement comes with the business side. If nurses are not equipped with financial acuity or financial background, I don't think it will support well with what they're doing. But will
Well, I
there
think
be
that's a different.
changes in the academia?
I think that's a different conversation, right? I don't think anything about reimbursement necessarily
Yeah.
is going to force the hands of changing education in the United States. I think there already is a strong debate around nursing
Mhm.
education, preparing nursing
Mhm.
graduates from the United States programs into being critically ready
Right.
to work on hospital
Mhm.
floors. Let's be very honest. We teach to the
Right.
NCLEX, same like everybody else here is, but the truth is the environments are so much more technologically heavy in the United States.
Mhm. That
The
is true.
reality is, I think most international nurses probably are going to be shocked stepping across and seeing that the machines monitor and assess and integrate
And
with
more advanced
significantly.
Yeah.
The old way of
significantly.
nursing is these machines do keep patients alive who 5 years ago would have been dead, right? So
Mhm.
having that skill set as a nurse to be able to manage 25 different pumps in the ICU
Mhm.
in suction
Mhm.
places, I mean, that is the kind of level
Yeah.
of
Different machines.
yes, that are going on.
Yeah.
What were you saying? And so I think that if one, I think there's a different conversation around education because most CNOs are saying nurses that are graduating in the United States are not clinically competent for those environments. And I think that there's a need, as of such, that nursing is designated as a STEM, science, technology, engineering, and mathematics program because billions of dollars that are invested in those professions have said no, it's inaccessible for the nursing population. And I think it's time that we start recognizing as our profession that we are a science-based profession. We are
Mhm.
technologically advanced, probably compared
Uh-huh.
much further than many other professions that have been designated along those lines. And that even mathematics and what we use to calculate every single day the weights of our patients to the correlations of the medications they are taking so that we can keep that person alive and not kill them is absolutely fundamentally necessary to a new designation. So there actually is now a coalition formed around identifying STEM, nursing as a STEM profession. The medical AMA is also going along this for doctors. And I think then also, if you guys are not aware, it also has a direct impact into being able to increase dramatic amounts of visa processes to have that also identified for another point of clarification. But Kay,
Right.
Dr. NursePaul, I think if there's something I would like to leave with your audience, it's nursing to me is still one of the greatest professions in the world. I do believe that it is the
Mhm.
profession that can break, especially largely women, out of poverty around the world. And what that means, I was talking to before the pandemic, the Minister of Economic Development for Honduras. And he said the reason so many people leave our country is there is no jobs for them in our country. So if we could start establishing nursing in countries where there is no development for women or for men who have access to education in places where the hierarchical and political systems are fragmented at best, we can change this. And actually, the Philippines is the prime example of how nursing changed an entire economic landscape for a nation. And the truth is I think we can continue to do that. And I still believe fundamentally that in the world, nursing in the United States is still light years ahead of probably nursing in most other
Mhm.
parts of the world. The
That
conditions
is
are
true.
far better than most other places in the world. The respect that nurses have within the American society, we are the number one trusted and respected profession in the United States. There is a huge amount of respect for our profession here from the general public when you are a nurse. And it is the one thing that if you become a nurse, the sky really is the limit. Like
Mhm.
Dr. Spall, you are
Yeah.
now a
Yeah.
nurse practitioner. You, Kay,
Mhm.
are running multiple, companies on the side. I mean, I think you're training yourself differently. But the truth is that once you become a nurse in the United States, whatever path you choose to take, if you are motivated and hardworking, the one thing also about the United States is it really is anything is possible. And that is the power of our profession in the future.
Right. And I wanna add to that, Rebecca, for myself, having worked both sides as a nurse and now as an NP that can reimburse for my service. I think what I've noticed in a lot of people that I work with, we have what I call, in one of the talks that I did last year, is what I call the bedside mentality. Nurses are stuck in bedside mentality. That's the apathy of feeling like, I just work here. I always hear this from a lot of people.
Yeah,
Like, I
that's
don't
like
care
I say,
anymore.
I just work here.
I
Ask
just work,
them.
like, I clock in, I clock out, I don't care.
Yeah,
But
that's
the problem is, the complexity of the issue keeps, growing. It's becoming, exacerbating. There's in the disease process, there's no remission to this problem. It's just exacerbating and growing and spreading because we've lost the passion to really fight for our profession. Um, with me, I'll give myself as an example because I know how much revenue. The first thing that I asked when I was entering this job, and I have multiple job offers before I accepted the job that I want right now, is how much volume do you want me to see in a day? If I'm working 12 hours, how much volume? So they said average 40. And I computed that to how many days I'm going to work. I put 99213, which is basically average visit. And I said, okay, I think I'm going to make this company at the minimum $500,000 for a year. At the minimum, that is if I don't crank more numbers for them or volume. And then they gave me this salary that is average for Houston. But I said, I had the power to negotiate it. My salary right now is 95th percentile based on AANP report. And I'm on my first year as an NP. I was able to negotiate my contract because I told them I think I can bring this much revenue to the company. And it's only like what, 25-30% of the actual revenue. What I'm trying to say is I did that because I am an informed professional. I know what I can bring to the table. And this is what I said in my talk last year about bedside mentality for nurses. The apathy that we have leads us to have our judgment clouded. And now we're only focused on the clinical part. They want us to focus on the clinical part so we don't learn to negotiate for ourselves. If we put out these issues out and we keep talking about it and we come together to, I mean, imagine 5 million nurses coming together and telling the healthcare industry, okay, hold on, let's talk about fair pay. If we probably could fix the situation, then probably nobody would need to travel away from their families and demand 100 an hour just so they can live the way that they want, that they can sustain their families. And nurses are, we're not only providing care physically, but we're also giving ourselves mentally and socially for our patients. We come home, we're drained, we're burnt out. But how do we keep nurses in the bedside? Like, nurses have to, like, also advocate for themselves. And I believe that if you want to change the world, you want to change your community, you start with yourself. So it's high time for nurses to introspect, evaluate, reflect. What can you contribute to the profession aside from you just working where you're working and clocking in and out, right? Start talking about these things. Start talking
Dr.
about.
Nurse Paul,
Uh,
I'm going to have
yeah.
you go and speak to my nurse practitioner friends because you're absolutely 100% correct. You need to start being able to measure the economic impact that you have. And
Mhm,
Kay, to your point, why can operating room nurses do this differently than most other professions? Because the OR
mhm.
is actually the only place that really makes money for hospitals.
Makes
So the
money.
number of cases in which they actually inform is why OR nurses are paid some of the highest salaries of any other profession of nursing in the country. So sorry to interrupt you on that one, Nurse Paul, but the truth
That's all right.
is that the reality is we're all going to start at the bottom, right? When you come to this country, when you're a new grad nurse, you have a 2-year period of time that you're going to
Mhm.
have to learn the ropes, right? That's
Yes.
their investment in you, your investment in the system. But once you start to get your feet underneath you, you are competent and you are, you know your worth and your value. You now know to start to have the conversations that Dr. Nurse Paul is talking about, to get out of the bedside mentality and looking at yourself as an asset that you can therefore
Mhm.
leverage within future conversations. But no, it's not going to happen on your first job. It's never going to happen within certain environments where you are under a contractual obligation to get you into this country, because that is the cost of coming to this country in many
Mhm.
situations. But after that period of time, you have an ability to do more with this degree than you would ever think is possible. And I love that for you.
And Rebecca, how can we help you advocate for the reimbursement model? Because this is really something that I'm really wanting to push for nurses, not only to my immigrant nurse community, but also to every nurse in the States, because we really need to talk about these things. I've seen the power of reimbursement as a person who's not, I'm only 8 months into my new job, but I definitely enjoy it. I have so much leverage. To be honest with you, this might sound very little, but I have my own parking space. My benefits, I have 7 weeks PTO. I can work as much or as little as I want for the facility, and they're still happy about me because I'm not a cost. I'm a revenue producer for them. So they're happy. I'm happy. My patients are happy. So I've never had to be screamed at in the bedside right now compared to when I was a nurse. And there, because I have also carry a very happy attitude to work, because I mean I'm satisfied with what I'm doing. So how
You
do
make
we
a
talk
very
about these things?
interesting point too, Dr. Pro, that you're happy, they're happier with you, that the level
Mhm.
of respect and the way they treat people who generate revenue for them are very, very different than the way
Right.
they treat the workforce who doesn't generate revenue for them,
Right.
right? And
I think I made a TikTok. Yeah, I think I made a short TikTok video about that. That why are nurses not getting this type of benefits? If nurses get these benefits, then I'd stay as a nurse. You know what I mean? But it's different because I have leverage because of my reimbursements. But how can we bring this forward?
Well, I think one, you just said it. And if the more you talk about it, the more you make TikToks, the more we educate that nurses are cost to healthcare systems and show the duplexity of the environment in which this does, like what your exact story is, I think is very powerful, Dr. Nurse Paul. Like, here's what I get as a nurse practitioner 8 months in. Here's what I was able to do. Here's the change of the environment I was in. That's very powerful. And the truth is, we just got to keep educating that we're a cost to healthcare systems and also the history behind it. Because I think one thing about America also is we recognize the mistakes of our historical places to correct them when it has been unjust and unfair. And we've done that numerous times, and I think this is the future. So keep talking about it. Please go to the Commission for Nurse Reimbursement.com. We're going to be having a convention, the summit in June in DC. And the truth is we are going to fight for this with the Center for Medicare and Medicaid Innovation to actually promote new kind of models that are happening. And the truth is even if we don't land where we want to be, the reality is that we drive this conversation forward is probably 5-10 years down the road before it happens. We'll start advocating for nurses to get an NPI number to be tracked within the value that they're adding into healthcare, even in value-based care. Currently, nurses don't largely have NPI numbers.
Yes.
So even value-based care means that the room will get all the credit for the work of the nurse. And you're going to start seeing us come out with new models, both aimed at ambulatory, inpatient hospitals. In fact, 2 of our commissioners have submitted a paper that was accepted immediately into health affairs with no changes on this, which has never been done for nurses. So I think the truth is there is a understanding of those in business that nursing is in trouble. And the truth is this is the first real solution that can solve this problem, because nothing else has. So thank you guys for having me. It was a real pleasure. You guys are both shaking up the future of nursing. You become voices of some of the largest workforces coming in globally. And we need more nurses like you out there using their voice, their platforms, and their expertise to drive the conversation of nursing into places that it hasn't been before. So you guys keep doing what you're doing, because it's an honor to be on with both of you. And I've watched your careers change. And it's just really impressive. And I'm super excited, because if you feel empowered to start having conversations like this, the truth is others are going to be feeling the same. So keep up the work that you're doing.
Oh my God, I think I'm blushing, although it's not showing. Coming
I
from
know.
Rebecca, someone I
I know.
idolize so
I
much. Oh
need
my
to
God.
pinch myself here. Like, wait, let me pinch myself. I'm
We all
blushing.
feel this way about ourselves, you guys. I know
But
it's so weird. And
you're
like, oh, yeah.
amazing.
And you're like, look, guys, every day is a fight, right? Like every day that you get out there is a
That's
fight.
true.
This is not easy. Change is not easy. And if people like to maintain the status quo, because if we change the status quo, it means the power structures that are in place that are benefiting off the backs of nursing means that we're asking them to play fair, right? And they're not. And this is an issue of fairness, right? I've worked for a lot of people who've made a lot of money off the back of nursing. And it's time that we change the models
Right.
so that we support and sustain this profession, because I can't imagine a world where there wouldn't be nursing, right? So that's what we're fighting for.
Thank you. Thank you so much. Thank you, everyone. One thing I want to share what I learned from Rebecca. You know, if you guys are listening here, you're in the 3-year commitment, 2-year commitment with your contracts, and you want to move forward with your advancement of career, move forward with your life, and help the nursing community, giving it back. One thing I learned from Rebecca, she said to me, "Okay, you cannot be, everything, because everybody thinks of me as a superwoman, right? They said you're a mom, you have kids, you have family, your dependents, you're sending money back to the Philippines, supporting family back home in my own country. You cannot be a nurse and a great nurse and a mother, advocate. You cannot be that person in one day." But you can be today, you're going to be a great nurse. Tomorrow, you're going to be a great mom. The next day, just take it one day at a time. Please spend time joining those conferences to educate yourself. Follow nurse leaders in LinkedIn that you will look
Mhm.
up into, and new nurses, immigrant nurses. You know, try to see what other people are doing. Be open minded, and right now you're trying to thread around the healthcare system of United States. And I would say Rebecca is one person that you probably want to follow in LinkedIn. And there's a lot more in there. Please open yourself, because I'm a bedside nurse for many, many years and I've never really jumped into LinkedIn. But after jumping into LinkedIn, I said, I was only seeing one part of nursing. Now I'm seeing both sides. And thank you so
Right.
much, Rebecca, for opening this very important topic and pushing, for the advocacy of nurses. Thank you for what you do.
Thank you guys.
Rebecca, thank you so much. We appreciate your time. That's really you've shared so many impactful things, and I wish we could invite you in future shows.
I would be glad to come to any future shows. However, I can
Yeah,
help you two be successful. Please let me know. I believe a rising tide raises all boats, and the more nurses who are successful in what they do, we should all be
yeah,
championing them on, because the more nurses who have success means the more success for our professions. So go out there and keep. That's the one thing I can say through. Go out and champion every nurse. If you're on LinkedIn, like, comment, expand, because the growing power of the nurses in this space that are having a voice and they're being heard is the first time I've ever seen it in my profession. So keep doing what you're doing.
And to be honest with you, it was Kay who inspired me to go to LinkedIn. I've only started the LinkedIn because it was required in my doctorate school. But oh my God, Kay
Record.
is right. I've always been Facebook and TikTok fronting person because I feel like I want to reach out to. I feel like I'm a grassroots leader. I want to be out there. I want to be. I want to be with my people, like pushing for advancements. But then I also have to see the other end where minors leaders are also talking about these things, because that gives me an overall picture of the situation. And thank you, Kay. Thank you, Rebecca, for being a top voice in LinkedIn for nurses. Guys, Rebecca is one of the top voices in LinkedIn. So LinkedIn is a space where we can talk about these issues. And the good thing with LinkedIn, corporate leaders, CEOs, hospital organizers, facilities, politicians are there. So we need to reach out to these people. We need to tell them, hey, it's time to focus on nurses. We are 5 million people here providing healthcare for everybody. If we can keep nurses happy, we can have a very high quality healthcare that we can rely on even as we all grow older for our family members. But yep.
Thank you. Any future conferences that you're a keynote speaker, Rebecca, that other people might consider?
Uh, yeah, quite a few actually.
Oh, may malat.
So LTC 100, that's taking place in Salt Lake City. It's for long-term care. I'm
Yeah.
not sure. It's sort of a closed kind of things, but Texas Nurses Association. I will be keynoting for Texas Nurses Association. So if you're a nurse in Texas, I'll be there in June. I'm also going to be
On
keynoting.
June.
That's
I want to
Paul.
go
Hey,
there.
Paul.
Yes.
Well, you should be
I still
coming.
have CMEs. I have CMEs and I have PTO. So yes, I can go there on
You should
June.
come and, in all honesty, look to get a table, see what you guys are doing. Like, I have to tell you, I think Texas nurses are one of the, Serena is doing a fantastic job leading that conversation on the national stage. Other ones, I'll put a list in. I can't remember where else everything is. I'm going to be gone a lot in May. Like Paul, I'm speaking for the Mass Coalition of Nurse Practitioners, keynoting for their organization in May. So nurse practitioners that are there, and host of others, and I just can't remember. But thanks for asking me, Kay. I should have been more prepared for that question. But if you guys are in Texas, come see us in June. I'll be in Cincinnati the end of this month for Cincinnati School of Nursing Innovation Conference. If you guys are in Cincinnati, and numerous other places that I can't recall off the top of my head. But so here's what we will have another conversation, you guys. Happy to come back and talk about how you grow and influence and find a voice, learn how to navigate social media, how to become a speaker, how to become a writer. Kay's going to be featured in a book that we're actually publishing. Dr. Paul, we should have you in this as well. But the truth is, you guys, the world is our future. And so we'll have a conversation more about that.
Thank you, Rebecca.
Okay,
we appreciate your time.
Thank you, guys.
Have a nice weekend, everyone. Thank you for everybody's listening. Hope you gained a lot of insight from this, Rebecca. We appreciate your time spending with us.
Yeah. And Kay, our next show for the month. Let's see our next show. All right, next week we're going to talk about current issues in nursing, our advocacies, and we might have Rebecca back again. She has not confirmed it.
Rebecca,
but thank you so much. Oh my God, I'm still blushing. But thank you, Rebecca, for gracing our show today. Kay, thank you for everything that you shared. And of course, more shows for us, Kay.
All right.
Cheers
See you guys
with my
next
coffee.
week. I know. See you guys next week. And have a extra sleep today. Go back to bed. Bye.
Bye.
Bye.